Welcome back, everyone, for updates in the treatment of depression and anxiety. It's my great honor to introduce to you Dr. Anne Emmerich, instructor of psychiatry, Harvard Medical School, and psychiatrist at the Mass General Hospital Division of Primary Care Psychiatry, interim director of the Mass General Hospital Department of Psychiatry Center for Community Connection and Enrichment, and the MGH Department of Psychiatry Director of Electronic Health Record Training. Dr. Emmerich has been a member of the MGH Department of Psychiatry for over 35 years, specializing in the outpatient care of patients with complex mental health issues and medical illnesses. Thank you, Dr. Emmerich.
Thank you, Mahmoud. It's so nice to be here. Do I start now?
Go ahead, please.
Okay. Hi, everyone. I'm Anne Emmerich. It's so nice to be with you today. As Mahmoud just said, I'm a psychiatrist in the Division of Primary Care Psychiatry. I actually spent the first 15 years of my career embedded in Mass General's medical primary care offices. So it's really always such a nice thing for me to be able to talk with primary care doctors. For some reason, my slides are not, oh, here we go. Okay. I have nothing to disclose today. My hope is that by the end of today, we'll have talked about I just pulled out a couple of concepts that I really want to focus on this year. One is the whole concept of whether patients are medication responders or medication non-responders, and then recognizing all the treatments that we have now that we didn't have even just a few years ago for patients for whom we think these non-responder patients may have response to other treatments that we can provide for them. I just want to start with some overall themes of psychiatric treatment. And these are things that I think are important regardless of what the patient's diagnosis is, things we should always be thinking about. And the first of those is every time we meet with a patient to be thinking about what stage of illness is the patient at. Are you meeting a patient who's having a first episode? Are you meeting a patient who's having a recurrence of a prior situation? Is this a patient where they've had recurrences, but the symptoms go away in between? Or is this a patient who has chronic symptoms that have really never remitted, no matter what kind of treatment they've had? We know there's a high percentage of reoccurrence for anxiety and depression, and we see that in two ways. One is what we call a diagnostically stable reoccurrence, a patient who has another episode of anxiety. Maybe they had panic attacks at one time, now they're having social anxiety. And then a diagnostically unstable reoccurrence, so patients who may have had panic attacks at one time and now, some years later, have an episode of depression. So we see these high rates of reoccurrence. We also want to know what the context is of the current episode. And a lot of my slides have a lot of information on them. They're there for you. And I'll be kind of just focusing on a few things on the slides. And for this one thing I wanted to focus on is the seasonal pattern, which is so important right now at this time of year. Is the patient somebody who has had seasonal episodes in the past? Is there a medication that has stopped working? So whatever medicine they're on, is it time for us to be thinking about switching? And especially the SSRI and SNRI medications. We know that each of these meds in any individual person seems to have kind of a shelf life, and at some point they might just stop working. We always want to think about what might be triggering the current episode, and there are so many triggers that can happen, as we know. I want to mention particularly the bottom of this slide, which is if a trigger, so often there is a trigger that if there really is, I can't find a trigger, I begin to wonder why. And so if a trigger isn't evident, it's important to ask if there's something about the patient that they have never discussed with us, whether it's recent or remote, and whether or not they think it's significant. I've been so many times in my career surprised to learn that there are things that even patients I thought I knew well for a number of years, there are very significant things that I never knew, and very often that the primary care provider never knew either. We want to think about the patient's prior treatment response. As I already alluded to, has this patient had a full response to one agent in the past? Have they had partial responses and had a history of augmentation strategies that we'll talk about in a few minutes? Or have they just never responded to medication? Have they had psychotherapy? And if they have, has it been the traditional psychodynamic therapy? We just go in and talk about what's going on. Or have they also had the skills-based therapy that we think is so important now? So cognitive behavioral therapy, dialectical behavioral therapy, acceptance and commitment therapy, these kinds of therapy. You can ask patients, have you had a therapy where you had homework to do, where you had some assignments in between sessions that you would talk about with your therapist? And then have they had trials of transcranial magnetic stimulation, ECT, ketamine? Have they had an inpatient admission or a partial hospital program admission? It's always important to document what meds people have had in the past, particularly if you're going to be a long-term provider for the patient. Insurance companies want that list before they'll approve things like ECT or TMS. In my office, anyone who's shared a patient with me will know I keep a long history at the top of every note that says all of these things. A lot of times I'm asked if diagnosis matters, because if we're going to give an SSRI anyway, does it matter what we're giving it for? And I would argue that actually, yes, treatment outcomes do improve if we make the correct diagnosis, but sometimes it can actually take a long time to figure out what that is. And one example I'll give here is we might have a patient being treated with fluoxetine 20 to 40 milligrams a day. That's Prozac. Maybe with little benefit for agoraphobia, the fear of leaving home alone. And maybe we're thinking of adding gabapentin, thinking that might help. But the medical student learns that the patient has worries about doing something embarrassing in public and wonders if the patient has OCD. So instead, we raise the fluoxetine to 80 milligrams. That's the recommended dose range for OCD, and the symptoms remit. So here it took a while to get to the right diagnosis, but eventually it did make a difference. And we know that many patients benefit from longitudinal care. Very often when we know patients, we can somewhat anticipate what might happen. If we know they've had seasonal depressions in the past, we can be talking to them in August about things we can do to reduce the risk for November. Let's start talking about depression. And we all know depression is a persistent feeling of sadness accompanied by at least 5 of what we call these SIGI CAPS symptoms. So changes in sleep, changes in the interest in things they would usually enjoy, dysphoric ruminations on themes of guilt or failure, changes in energy, concentration, appetite, psychomotor slowing or psychomotor agitation or restlessness, loss of interest in sexual activity, or suicidal thoughts. And there are various types of depression. As I said, right now, this time of year, we see a lot of seasonal depression. There's the melancholic depression where people are really slowed. There are people who are more anxious and restless. There's the atypical depression where people are sleeping more, eating more. Very important, does this patient have any history of mania or hypomania, which could seem like episodes of euphoria, but it could also seem like episodes of irritability. And then what is the severity of the depression? So I think about this in the following way. If a person has sadness and some other symptoms, but there's no functional impairment, no suicidal thoughts, nothing like that, we would classify that as mild depression. If the patient now has symptoms and they're also beginning to have some functional impairment, maybe they're still getting to work, but they're not going out socially. Maybe they stayed home from work a day or two last week because of their depression, still no suicidal thoughts, still eating okay, that would be moderate depression. And then severe depression, of course, the higher risk symptoms, so particularly things like not eating, losing weight, suicidal thoughts, homicidal thoughts, ruminations they just cannot control at all, or psychosis. And then, of course, we think about what level of care is appropriate. So is this a patient for whom outpatient continues to be the right level of care, or do they really need something more, such as an inpatient admission or what we call partial hospitals, where people sleep at home at night, but they go to 6 hours of programming every day for 2 weeks. And then, of course, as I started to say earlier, what is their response history to medication? Are they a medication responder, a partial responder, or a non-responder? So I'd like to start with a case. This is a 60-year-old man. This man I've known for many decades. He started having depression around age 30. He was very anxious at that time also. He's less anxious now because he's achieved financial stability, and that was a big part of his anxiety in the beginning. He did have a harsh upbringing, but he doesn't have any PTSD. He does have a family history of depression and of psychosis, and a brother committed suicide a couple of years ago, right around the age the patient is now. He has a lot of strengths, a lot of what we call protective factors. He's a nice person, nice personality, good connections to people, hardworking. He doesn't drink. He doesn't use substances. He hasn't had psychosis. In the early years, so really the first 15 years, he did not want to take typical antidepressants, SSRIs, SNRIs, Prozac, Zoloft, Cymbalta, any of those. And he trialed bupropion and lamotrigine, Wellbutrin and Lamictal for many years, and benzodiazepines and Buspar for his anxiety. He'd get a bit better, a bit worse. His symptoms never really went away. He felt lonely. He felt worried. His career was stalled. And eventually I persuaded him to try an SSRI. The first one was Celexa, and he went into full remission of his depression. He developed relationships and hobbies. His career flourished. But the problem is he always gets severe sexual side effects to the medication. And after a little bit of time, he decides to go off again. So we tried all the other SSRI and SNRI meds. He had sexual dysfunction with all of them. We tried adding Viagra and bupropion and buspirone, all these things that there are some reports they might help with sexual dysfunction. Nothing helped. He would go off medication. Every time he went off, the sexual dysfunction would go away, but the depression would come back. And he's really tried everything. So he's had psychodynamic and CBT therapy. He's done mindfulness practices. We've augmented with antipsychotics. He wanted to try psychedelics, and he got some from his dog walker and tried them on his own. He's gone to a private practice for ketamine, intramuscular ketamine. Nothing really worked. But he went back on Cymbalta, and his depression fully went away again. And the sexual dysfunction returned. So this patient is a medication responder. He and I know what we can do to take care of the depression. Unfortunately, he has a bad side effect that really bothers him. And so he'll be on medicine for 18 months, and then he'll be off for 6 months, and then he'll go back on again, back and forth. But he does respond to medication. I often get asked which SSRI I like best. And my answer is that I actually like them all. And part of that is because I know the difference between them. And so that helps guide my choices. And I've just listed them here alphabetically. So citalopram Celexa is the one for which we have the warnings about QTC prolongation. The FDA some years ago saw that as you go up on the dose of citalopram, QTC prolongation occurs. You have to be careful. There are dosage guidelines for people over age 60 or who are on other meds that can cause these problems. Escitalopram, Lexapro, has the same tendency according to a big chart review that was done, but the FDA has not given any warning about it. Fluoxetine is a great medication, but it has a lot of medication interactions, including with the tricyclic meds that are often used for pain, headaches, things like that. Fluvoxamine we mainly use for OCD, paroxetine, Paxil. A lot of primary care providers use this for anxiety. It's probably less stimulating, and that's probably why it helps a bit more there, but it does tend to cause a lot of withdrawal symptoms. And then sertraline has the fewest of the medication interactions and does not seem to cause QTC issues, but for some patients, it does seem to have more GI side effects. We often use Wellbutrin or mirtazapine early as first meds for depression. Wellbutrin for the people who are sleeping too much or who say they don't want a med that will cause weight gain or sexual dysfunction. Mirtazapine also does not cause sexual dysfunction. These are the only two we have really that don't cause it. But mirtazapine will cause weight gain. With Wellbutrin, important always to remember about the seizure risk of Wellbutrin. Carefully titrate up on the dose. Carefully take a history. I have seen a few patients have seizures on Wellbutrin, so it's something we really do need to pay attention to. One particular case recently that I had, a woman was on, I think it might have been Trileptal for migraine prevention and was on a high dose of Wellbutrin. She started getting Botox for her migraines, and they stopped the Trileptal, and she had a seizure at work one day. So we have to be thinking about this all the time with Wellbutrin. We want to start low and titrate up with all antidepressants because of side effects. We want to tell patients that it's going to take a while for the medicine to work. So I don't expect you to be feeling better in less than 4 to 6 weeks, but I do want to know if you're tolerating the medicine and if you've been able to titrate up as instructed. We know the common side effects are GI side effects, sleep issues, sexual dysfunction. Some reports of increased risk of GI bleeding if patients are on chronic use of nonsteroidals. For insomnia, I tell people to start early in the day with food for both the insomnia and the GI side effects. And I say about 20% of people actually find these meds sedating. And so if you are one of those people, it's okay to take it in the evening. The SNRIs like venlafaxine and duloxetine, Effexor, and Cymbalta, we usually start those after SSRIs, but some psychiatrists start them right away. Here, a bit more in the way of side effects, so really important to titrate up slowly in the beginning, not so slow that you're not doing it, but just to remember that titration is important. I have some examples here of how to titrate. I'm always thinking about what dose am I trying to get to. So for instance, if a patient is under age 60 and I'm starting them on citalopram, I'm thinking about the fact that I want to get to 40 milligrams. Duloxetine, I'm thinking about the fact I want to get to 60 milligrams. Wellbutrin, I'm thinking about the fact that I want to get to 300. Now, if a patient's doing well on a lower dose, they're really doing well, I don't need to get to those doses. But that's where I need to get for most people. And so I usually am thinking about both where I want to get and what dosage sizes are available, and then titrating using those. So for instance, for citalopram, I might do 10 milligrams for a week, then 20 for a week, then 30 for a week, and then 40. Or duloxetine, 20 for a week, then 40 for a week, then 60. Wellbutrin, I always start with the small 75 milligram ones and titrate up from there. Set expectations, remind patients that the response will not be linear. There's going to be good days and bad days before they feel well. And this can be a kind of scary thing for people with depression if they have a good day and then all of a sudden they have 2 bad days. And it's important that we remind them that this is actually the way it works. This is going to happen. Sometimes patients will call me in a panic thinking the medicine has stopped working. And I'll say, no, this is just how it works in the beginning. We want to get to full dose and we want to achieve remission. There is antidepressant discontinuation syndrome for most antidepressants, dizziness, irritability, flu-type feelings, electric zap sensations. About 60% of patients in some studies will show this, so we want to taper down slowly. The worst ones are Paxil, Cymbalta, Effexor, Pristiq, but all of the others can also do it, except for Wellbutrin, which is not an SSRI or SNRI. Fluoxetine has the lowest risk because it stays in the body the longest, takes 5 weeks to leave the body. If I'm totally stopping a medicine, I'm going to do a slow taper. So maybe go down by 25% every month. If patients start to have withdrawal symptoms, we go back up to the last dose that they were comfortable on and taper more slowly. Sometimes we use a fluoxetine substitution. We might give a bolus of fluoxetine for a couple of days, maybe 60 milligrams of fluoxetine while we're taking a person off of another medicine if they're having a lot of trouble getting off of it. So this second, so case number 2 is a 69-year-old woman who has severe anxiety and depression. This started about 15 years ago for her. She was really doing fine in life, and she had some severe medical problems that led her to have to stop working. She became very isolated, very depressed. She has COPD. She's on home oxygen, a lot of other medical problems. Her mother died last year, so now things are a lot worse. She took Celexa with benefit in the early years, but about 10 years ago, she had to go on dofetilide, Atticussin for AFib and flutter, and had to stop the citalopram. Remember, I said citalopram can cause QTC prolongation, and her baseline QTC has been in the 0.47 to 0.5 range. So she's been very depressed. She's very anxious. She really is never feels pleasure. She cries all the time in our appointments. She also feels meds are the only answer. She doesn't like to go to therapy, and she really has not engaged in other treatments. She had a lot of medication trials in the past few years, and I show this list to show that what I've indicated here is not that they didn't work, but that she had a lot of side effects. So if we added bupropion, she got very anxious. If we added Remeron, she got too sedated. Duloxetine caused blurry vision. Pristiq made her irritable. We tried Abilify augmentation. She got headaches. And so this medication regimen for her falls into what we call the combination therapy and augmentation therapy strategy. So combination, 2 antidepressants from different categories. We do that to reduce the risk of side effects and to reduce the risk of serotonin syndrome. So you might use an SSRI with Wellbutrin or venlafaxine with mirtazapine. And then there's also augmentation therapy where we add something that's not an antidepressant. And here I have a list of very common augmenting agents. There are some that are off-label that we've been using a lot of these for a long time now: lithium, lamotrigine, Buspar, modafinil. And then there are some FDA-approved meds for antidepressant augmentation. And here there are quite a few just in the past couple of years, past few years. So aripiprazole, Abilify, brexpiprazole, Rexulti, you're seeing that on the television all the time now, quetiapine XR, and then cariprazine, which is Vraylar. Also, you see that one on the television a lot now. And then there are some newer antidepressants in recent years, the Vibryd and the Trintellix. Again, I have a list here for you of side effects. I'm not going to dwell on that for right now. So in this case, this woman who really, her whole life changed when she started having medical problems, one of which is really pretty significant COPD. She's in the hospital right now. She's also very anxious. With her, it's been hard for me to know if she actually would be a med responder because she has so many side effects to medications. She appears to meet criteria for treatment-resistant depression. And so with her, we've made a referral for transcranial magnetic stimulation, trying to get away from all the side effects that she's been having with meds. Treatment-resistant depression, there are a couple of different definitions for it. The FDA says if a patient fails to respond to 2 antidepressants, insurance companies say if a patient has failed to respond or has had intolerance of at least 4 meds from 2 different categories, they see that as treatment-resistant depression. It's actually a phrase that I hate. I don't like to say to patients, you have treatment-resistant depression, because I think the phrase implies they're not going to get better, and I don't believe that for most of my patients. It's just that it's not going to be through medication, maybe. TMS, transcranial magnetic stimulation, approved for unipolar depression, not approved for bipolar depression. Patients who have a history of bipolar disorder, that's an exclusionary condition for TMS because it can trigger mania. Patients go every day for 30 minutes, and they do that for 36 treatments, so about 6 weeks. It seems to, there is evidence for reduction of suicidal thinking with TMS. TMS is a magnetic pulse across the skull. So we all know that ECT, our traditional treatment for treatment-resistant depression, is an electrical current, induces a seizure. People need to have anesthesia for ECT. They get memory loss. None of that with TMS. Patients can drive their car. They can go to work the same day they have the treatment. Patients who cannot have TMS, people with any kind of metal implant in their body. I have a patient who now has a cochlear implant. TMS worked for her in the past, but now she's not eligible for it. And as I said, anyone with bipolar disorder. And so now I'm going to start a third case. So the first man we talked about was a medication responder. He would get bad sexual dysfunction, but he did respond to meds. Second patient had a lot of side effects with meds. It's kind of hard to know whether she would respond if she could actually take them. And referred her for TMS. Now, case number 3 is a 57-year-old woman. This woman's depression goes all the way back to her childhood. Her parents were Holocaust refugees. Her dad had episodes of depression. She has comorbid PTSD. She actually witnessed the murder of a coworker once. She had a suicide attempt in her early 20s by overdose. She has chronic intermittent suicidal thoughts, sometimes with a plan. At one point, she said that if her dog died, she would kill herself. Luckily, we got through that. But she's always been a patient I've worried about a lot. She has a chaotic relationship history. She has some binge eating disorder, but she's never been psychotic, and she does not use substances. She's had a few hospitalizations for depression. She's had many med trials. Nothing helps. Fluoxetine, she's better on it than off of it, so we always return to that. And she takes a psychostimulant for her binge eating disorder. She did try ECT a few years ago with no benefit. She's had a lot of different psychotherapies, individual therapies, group therapies. And recently, the past year, about a year ago, her situation started to really deteriorate again. She had she was on a leave of absence from work for depression. She was very worried she was going to get fired when she went back to work, and she said she would kill herself if that happened. So again, this is another patient for whom the term treatment-resistant depression would be appropriate. We know that in addition to TMS, we have ECT. There is now vagal nerve stimulation. Mass General has a study for patients who have Medicare for vagal nerve stimulation. And then we know that we should always be referring patients for evidence-based therapies. So for patients with more severe depression, have they had good CBT? Have they had DBT, dialectical behavioral therapy? We sometimes might think DBT is only for people with borderline personality disorder, but in fact, that's not true. Many patients with depression have the dialectical thinking, right? Things are all or nothing for them. They feel terrible, they see no hope, and the only thing that they think would make a difference is if they were successful or something like that. And so there's a dialectical thought pattern, even if they don't have the borderline personality disorder for which DBT was originally created. ACT, acceptance and commitment therapy, very effective for some people. And in the trauma therapies, there is some evidence that EMDR, the rapid eye movement therapy, may help with treatment-resistant depression. Now we also have ketamine, S-ketamine. So ketamine, unlike the traditional antidepressants, which work on serotonin, norepinephrine, maybe a bit of dopamine, ketamine is an NMDA receptor antagonist, works really impacts the glutamine system of the body. S-ketamine, the second one that I have mentioned here, Spravato, is the only one that's actually FDA approved for depression or for any psych indication. And it is covered by most insurers. Racemic ketamine, which is the intravenous ketamine, it's an off-label use. And right now, here in Massachusetts at least, is only covered by Blue Cross and MGB. There is an intramuscular form of ketamine also that is being used by some psychiatrists in private practice. So some patients can get that through private pay, and that can approximate the dose of the intravenous racemic ketamine. Some studies suggest that S-ketamine is maybe not quite as effective as racemic ketamine, and we're still not sure about that. So there's increasing evidence that ketamine does reduce suicidal thinking in some patients with severe treatment refractory depression. The S-ketamine, which is the only one that's FDA approved, is only available through a REMS strategy, meaning patients have to have the administration of the med in an office, and then they must be observed for 2 hours for any emergence of sedation or dissociation. Because the other forms of ketamine are not FDA approved, they don't have REMS strategies attached to them, but it is the professional standard right now that any patient receiving any form of ketamine, it's done under the supervision of a physician or provider. I don't mean to say physician only, providers specifically trained to use this form of treatment, and that they're observed for several hours after the administration. And as we would assume, ketamine is a dissociative agent, an anesthetic agent. Patients should not drive or work the day that they have a ketamine treatment. There are some exclusions for ketamine. Unlike TMS, patients with bipolar disorder can have ketamine treatment, but patients who have had a prior history of psychosis, it is not recommended for them. Patients with COPD, some patients with asthma, patients with uncontrolled hypertension or cardiovascular disease may not be eligible for the treatment. So my patient that I mentioned, my second case, the woman who had COPD, she would not be a candidate for ketamine. So here we have the woman who had been depressed since childhood. Parents were Holocaust refugees. She's taken many meds. She's had many forms of treatment, but has a lot of suicidal ideation. This patient I did refer for ketamine evaluation, and initially, because her insurance didn't cover it, her family helped her to pay for about 8 sessions out of pocket. Right now, sessions, I think, out of pocket run about $450, which is a lot of money, but for some patients, it's now that they can get 8 sessions for around $5,000, where even as little as 2 or 3 years ago, it was $25,000 at that point. For this patient, her suicidal thoughts remitted. She started seeing her therapist, the morning after her ketamine sessions. And one of the things we're finding is that for some patients, there seems to be this window of about 24 to 48 hours during which their mind is maybe more receptive to therapy, or some memories or some alternative ways of thinking about their life are more available to them. This woman continues maintenance ketamine sessions. She has one session a month. She's no longer reporting suicidal thoughts. She's actually just lost another job since I wrote this slide. And although she's upset, she is not at all the way she was before. She's not reporting suicidal thoughts. Now that ketamine is more available, we also have a glutamatergic antidepressant that was approved in 2022, which is Auvelity. Many people have not even heard of it yet. Auvelity is a combination medication. It's 105 milligrams of bupropion and 45 milligrams of dextromethorphan per tablet. We start with one pill daily for several days and then move to one pill twice a day with at least 8 hours between doses. In Auvelity, those of us who are used to prescribing bupropion would be assuming that the bupropion is the antidepressant, but in fact, with Auvelity, the dextromethorphan is the antidepressant. And the dextromethorphan is an NMDA receptor antagonist and a sigma-1 receptor agonist. It modulates glutamatergic neurotransmission. The bupropion inhibits the metabolism of the dextromethorphan, thus boosting the dose of dextromethorphan and really facilitating the antidepressant impact of it. And studies show that the action of onset for Auvelity may be 1 to 2 weeks compared to our traditional antidepressants, which are more like 6 to 8 weeks. I have started using it because the ketamine clinic here at Mass General is beginning to think that maybe Auvelity helps augment the ketamine treatment that some of my patients are getting. I do have one patient who's had a very robust and good response to it, and several others who I don't know enough yet, but people seem to be tolerating it. For some patients who may not be able to tolerate the full dose of the Auvelity, we could be prescribing bupropion and dextromethorphan separately, so starting with lower doses of dextromethorphan. One patient has asked me if it's okay for them to go back up to 400 milligrams of bupropion the way they were on before. And I've had to point out to them that that would not be safe because in this case, the bupropion is boosting the dextromethorphan, and we don't want to do that at the 400 milligrams of bupropion level. So. Psychedelics, we still don't have. There's still no treatment outside of studies. Most recently, last August, the FDA rejected the use of MDMA for PTSD. I don't think any approvals are coming very soon. Despite that, it's being written about everywhere. Last year, the American Journal of Psychiatry had a whole special issue on psychedelics. Precision psychiatry, we really don't have too much information that's any different right now. There are a lot of studies going on. One of the things that we know is that maybe a lot of the studies were traditionally done in certain populations of people, and now that a wider mix of people are signing up for studies, maybe there will be new models that we'll be finding. Genetic testing really doesn't guide diagnosis for us. It can give us sometimes some information about how patients metabolize. Often we don't get the testing until patients have already not responded to a lot of medications or had a lot of side effects, and we find the profile doesn't always correlate with the side effects that they're having. But there is one case where genetic testing sometimes can be helpful, and that's the small percentage of people who actually have reduction in folic acid conversion, the MTHFR mutation, which the standard genetic testing for psych meds tests for. And there, Deplin, which is a form of L-methylfolate, which seems to have better penetration of the blood-brain barrier. If the genetic testing shows that the patient has the significantly reduced version of the mutation, sometimes insurance companies will pay for this, and that would be ultimately 15 milligrams daily. Seasonal affective disorder. This time of year, I'm always talking to patients about light boxes. We know that there is efficacy for bright light therapy. Patients can do this at home. I'm always telling patients that they can buy these devices at Target or on Amazon, they have names like Happy Light or Sad Light, sad being seasonal affective disorder, or light box therapy. Nowadays, they cost about $40, $45. I always let patients know if the price is too good, if it's like $20, then that's probably a 3,500 lux light box, and that's not the right dose. So, two pieces of information I want people to know: get the 10,000 lux box, and then every morning, 30 to 45 minutes. Follow the instructions. I say to them, put it on your counter, be reading your newspaper, be watching the TV, have it shining on your face, but not looking directly at the light. And I always tell people it's okay if you've glanced at the light because patients will get nervous about that, but we don't want them sitting actually looking directly at it. What about bipolar disorder and how does that impact depression treatment? We know that if people have a history of bipolar disorder, they are more at risk to switch to mania. So we try to avoid antidepressants if possible in patients with bipolar 1 disorder. And if we really have to start an antidepressant, we always want to make sure that the patient is on a mood stabilizer. For bipolar 1, we would want lithium or Depakote, one of the atypical antipsychotic meds that are now used as mood stabilizers. Consider ECT if they've had a swing to mania while on mood stabilizers. Bipolar 2, these are the patients where we see this cycling of mood, but it's not to the level of full mania. There was a study done a few years ago that said, well, what do psychiatrists do in this situation? And it showed that the majority of psychiatrists prefer to have some kind of mood stabilizer in place if they're going to treat depression in patients with bipolar 2. So we see a lot of gabapentin and lamotrigine in bipolar 2, less side effects than the Depakote and lithium, but still seeming to offer safety. And so if you see a patient who's on lamotrigine or lithium even, you can never assume what that means. A patient might be on lithium for bipolar disorder, but they might be on it just for depression augmentation. Lamotrigine, it's a common choice for depression in patients with both bipolar 1 and bipolar 2. I just want to show you here, there is a wonderful website for women who are pregnant or postpartum. We know there's a high percentage of relapse in women who discontinue meds, but many women need to stay on meds. The Mass General Center for Women's Mental Health is just a wonderful resource. Their website, it can take a long time to get an appointment, but in 2 minutes you can be on their website, and they have a lot of very useful information. I'll talk quickly about anxiety. Not too much to say that's different from prior years. I did see this amazing quote just recently after I made the slides that you all have. I was in Indiana on vacation a couple of weeks ago, and this quote was tacked on a store wall, and it said, "Thoughts are like fire. They can cook your food or they can burn you alive." And I think for patients with anxiety, that can be so much what it feels like sometimes. We know the U.S. Preventive Services Task Force recommends the primary care providers screen for anxiety under age 65. We know there's a lot of comorbidity between anxiety, depression, OCD, obsessive compulsive disorder, and substance use disorders. We know the GAD-7 is a good screening tool. Probably many of you are using that. And if you're in a busy day and a patient's filled out one of those, you can take a quick look at it, even if you don't have time for too much else. And you can see from the score whether this is a person with really minimal symptoms of anxiety or with more severe symptoms. And the GAD-7 screens for GAD, panic disorder, and social anxiety disorder. This case is a 39-year-old man who comes in with acute onset of shortness of breath, rapid heart rate, sweating. He's been to the emergency room. He's been told he's having panic attacks. He was given some gabapentin. He's a busy man. He's got kids. He's got a wife. He's a plumber. He's always getting called out for emergencies. He doesn't drink or use hard drugs, but he chews tobacco. He uses marijuana, and he drinks 6 cups of coffee a day. We all know where I'm going with this, I'm sure. He's never seen a therapist or a psychiatrist, and he doesn't have a family history of anxiety. There are in Massachusetts community behavioral health centers where we can get sometimes rapid treatment for people. We would want to try to get this man some rapid psychotherapy, which is very hard to do. Because it's so hard to get a therapist, it's good for all of us to know some grounding techniques that we can just teach patients quickly in the office. There are lots of them online. This is one that I've put here that I'll just share with you, but there are so many others, just to talk to patients about how it is possible to direct their attention away from their panic state to the present moment. And so to say to them, just like you to sit for a minute and just notice 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. Just teach that to patients. I know here at Mass General, I believe in the ICU, the nurses use these kinds of grounding techniques for themselves, and they teach all the student nurses when they come in. You can always like step into the spare room for a minute and just do this when you're feeling stressed. We know that cognitive behavioral therapy is first-line treatment for anxiety disorders, well suited to primary care settings. This Olivia Bogucki is actually here in my clinic. She did this in 2021. The stress management and resiliency training programs, mind-body programs. Here at Mass General, we have the Benson Henry Institute. UMass Worcester has an amazing mind-body program that they've had for decades. I understand people call in from all over the world to use their program. For meds, it's the usual meds. Nothing has changed at all. What I want to talk about just quickly is choose medication based on the frequency of the symptoms. If a patient has anxiety only when they're on an airplane, only when they're giving a CME talk to primary care providers, give them a PRN medication, a beta blocker, or a benzodiazepine or hydroxyzine, and have them practice it on a different day in case it lowers their blood pressure or makes them a little dizzy. People who have frequent symptoms really need daily meds, and that's where we start talking about SSRIs, SNRIs, gabapentin, buspirone. I have a little spiel I give patients about rescue meds and maintenance meds. A lot of times I'll say, do you have anybody in your family that has asthma? Are you familiar with kind of how patients with asthma use rescue meds and maintenance meds? And so I say, if you need to use a benzodiazepine 2 or more times a week for panic attacks, to me, that's a sign we should be talking about a daily preventive med, such as an SSRI. These meds take the same amount of time to work for anxiety as for depression, so 4 to 8 weeks. So sometimes we do need to use that benzodiazepine in the interim if the patient is having a lot of symptoms. Atypical antipsychotics are often used, but should really be the last choice because of all the side effects, particularly metabolic syndrome, movement disorders. I gave a slide earlier about the augmentation strategies and all the newer atypical antipsychotics that are approved for augmentation in depression. I am seeing a lot more movement issues in my patients now with these meds. So, during the era where we were using a lot of clozapine and olanzapine, we were seeing a lot more of the metabolic side effects and fewer of the movement side effects. But with these newer meds, we are seeing a lot of movement issues. It's really important that we see patients in person periodically if they're on these meds, because we may not see those movements while the patient is on Zoom. So this patient, he was started on gabapentin, 100 milligrams 3 times a day, still going to the emergency room. So the primary care provider titrates him up to 600 TID, but he's still having panic attacks. He doesn't have time to go to a partial hospital program. He doesn't have anybody to cover his plumbing business. He gets started on Zoloft, Ativan, Seroquel. Eventually, he's on 150 of Zoloft. He's not going to the emergency room anymore, but he's still needing Ativan a few times a week. In this case, his wife starts to see a therapist, and he starts listening to her mindfulness meditation tapes with her. And his primary care provider continues to work with him on decreasing or eliminating caffeine, tobacco, marijuana. Sometimes we really have to work at this for a long time. 6 months later, the patient has done these things. He's reducing his use. He's using Ativan less often, but he's still very stressed. The primary care provider starts talking to him about mindfulness, and the patient starts swimming. He's taking his kids to their swimming lessons anyway, so he starts swimming laps while he's there. And 6 months later, he's doing better. He's still on the Zoloft, but he doesn't need the Seroquel anymore for sleep. And he just carries some Ativan with him so that he knows he has something on hand if he has a panic attack, which he almost never has now. I think we cannot say enough about the impact of mindfulness, but also how much work it is for people to start doing it. And we shouldn't discount that. It is a lot of work. I love this quote from Deepak Chopra. Meditation is not a way of making your mind quiet. It's a way of entering into the quiet that is already there. buried under the 50,000 thoughts the average person thinks every day. So physicians' engagement with mindful medicine influences their likelihood of recommending it, and addressing the barriers that we have can help. And there's a thing here from the Journal of Lifestyle Medicine. And then there's also this wonderful quote from Bob Waldinger, who is people call him the happiness man, but he's the leader of the Harvard study on adult development, who talks a lot about happiness and well-being. He says, try meditation and see if it makes you feel like you want to do it again. If so, that's great. But if meditation doesn't call to you, find some other happy place. Maybe it's walking in nature, maybe it's playing soccer, it could be anything. Find your place of absorption in the present moment. And I think that so often for patients with anxiety, it's really hard for them to get to this. And so we just need to slowly but surely keep encouraging it. I'm just going to say a quick thing, Mamuda, before I stop. We all know that suicide is going up. I just want to point out suicide by firearms remains so concerning, including in women who traditionally we didn't really think of. So many people think that the West Coast and the East Coast are filled with stressed out, depressed people, but the map would indicate that the middle of the country is really struggling so much in terms of suicide risk. We know everybody's at risk, but teenage girls we're especially worried about. And I just want to say one thing, this is my last slide, on the Stanley Brown Safety Plan or other safety plans. Just as we talk about these skills therapies that increase emotional skills, having a safety plan, just as a person might have an asthma safety plan, having a safety plan for when they have suicidal thoughts can be so helpful. These are easy things to start implementing if you have practices where you have some nurses or social workers who are interested in these things. This is something you can look up. I didn't show it because there are copyright issues on it, but you can look it up. And the last thing I want to say is, even if the patient is receiving all their meds from a psychiatrist or a psychiatric practitioner, primary care providers have a vital role in supporting treatment. You often are so helpful in encouraging adherence and monitoring for side effects and reoccurrences. And I will just say, if you harbor implicit biases against psychiatrists, patients pick up on that also. And so I do urge you, if you, for whatever reason, don't feel good about psychiatrists, get to know more of us and give us a chance. Okay, that's it.
Thank you so much, Dr. Emmerich, for a whirlwind of two very important.
I'm sorry, there's so much to talk about always on this topic.
There is, and lots of great questions here as well. You know, this is something we had in Dr. Mohika's sleep talk as well, but could you discuss your approaches to weaning benzodiazepines? Since
To weaning them?
Yes.
Yes, okay, sure. So when we have a patient who wants to come off of benzodiazepines, and we are encouraging people more now, especially who have been on for many years, to try coming down on the dose. I think a lot has to do with how long a person has been on the medication. People who have been on benzodiazepines for many years, we're going to do this very slowly because we want them to feel safe about doing it also. And so if they're on something like 3 milligrams a day of clonazepam, I might say, for instance, let's try to get you down to 2 milligrams. And I might do that as going down by 1/4 milligram every month. And then we see how they do with that and then continue from there. We really do need to go slowly when people have been on them for a long time. And I would say that in doing that, I find that some patients, we begin to realize that maybe they really didn't need it as much anymore and they had gotten better through the years and we just didn't know that. And maybe 50% of patients really wind up still back on the original dose that they started on.
That's great. Actually, somebody has mentioned here as well that they've found 9 to 12 months for a very slow.
Yes. And one of the very important things is to educate people that the withdrawal symptom feels the same as their anxiety. And so that we're going to go very slowly so that we're sure they're not having withdrawal. But if I get calls from people within the first couple of days, then I'm saying, well, this is probably some withdrawal because your anxiety wouldn't start up again that fast. So it's this often confusion. And very often patients will say, well, I tried once and it didn't go well and I went back up. And what happened is they actually had withdrawal. And so they went back up and they've been afraid to try again.
Got it. Yeah, it's tough, but they're very, very slow. Uh,
Yeah.
seems to be the key. And in primary care, we have patients with a lot of serotonin-nergic medications. Can you comment on early recognition of serotonin syndrome? What would
Sure. I think one of the classic symptoms that you might see is twitching. And serotonin syndrome does not really happen all that often. But the cases that I've seen, the most distinctive thing was that the patient was having some kind of twitching. Some One woman was having twitching of her abdominal muscles. Another person was having some facial twitching. So of course we're looking for changes in vital signs or agitation or sweating or things like that. But twitching is, if I see twitching, I'm immediately thinking that.
got it? And any good questionnaires in primary care that we can use for screening for bipolar disorder?
Oh, I'm not sure which one, if any have been validated for primary care practices. I apologize, I don't know the answer to that. Certainly, you want to be asking about things like sustained periods of not sleeping, sustained periods of excessive spending, impulsive decisions, things like that.
And certainly, do you feel like using the PHQ-9 and GAD-7 to screen before treatment initiation just to see how they're doing?
For depression and anxiety,
And
I know
yes,
they're recommended for primary care practices. Yeah.
certainly for us, it helps us with being able to get people into services. Um,
And I think that's the importance of them, right? Is when you're in a busy primary care practice, I imagine you could miss some things because you just haven't had time to talk about it. So those screening tools give you a bit of a marker for who to pay attention to.
and some self-reflection from the patient. Um, and so patients with the passive suicidal thought but has no plan, is it safe to start that SSRI because it'll help their depression but may worsen the suicidality?
Oh, great question. Thank you. Yes, so there is a black box warning on most antidepressants about that up to, I think, now age 26,
Mhm.
26 or 27. So we know in younger people where we start antidepressants, that's a concern. So in younger people, I'm really going to want to try harder, particularly if they're quite a bit younger, more like 20, 21, really want to be trying harder to say, hey, how about if we have one of your parents come in or a sibling or a friend or somebody who can help you to think about how you're feeling and help you to think about calling me if you're having any issues. And of course, we want to be warning people about this and making sure that they call us.
Excellent. And then any thoughts on how effective buspirone is for sexual side effects?
Buspirone. So all of these things, it's really more anecdotal reports. And I will say, for most patients, the thing that seems to work best is having a conversation with them about the fact that the sexual side effect of the medications is related to the dose you just took,
Hmm.
rather than all the antidepressant effect takes weeks, but the side effect is related to the dose you just took. So I just had someone the other day where I talked with them about having sexual activity before they take the medications. I said, when your boyfriend is coming over, don't like take your meds because you think, good, I'll get everything out of the way. He's coming over. Wait and take your medicine after he's after. And for some patients, that's what works. And some patients who are stable on medication, sometimes what they will do is they will maybe have one day a week that they don't take the medication. And sometimes their sexual function is better. But we do try all those other things.
Okay. It's and
It is a difficult side effect. There's no question. Yeah.
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 Uh, and now we do see this with people with dementia. So, patient with progressive dementia, lifelong history of depression, which had been well controlled, but and PTSD. But now the depression is worse, and the usual medications are not effective.
Mhm.
What are your
Mhm.
recommendations?
Yeah. So, I mean, without knowing the patient, some patients like that will have ECT, which seems almost paradoxical to think that a patient with dementia would have ECT, but sometimes it can be helpful. If it's a more agitated depression, um, and it's a patient with Alzheimer's disease, Rexulti is approved for agitation in patients with Alzheimer's disease. So sometimes when it's dementia, to really think through, is this depression or is it agitation?
Got it. And which SSRIs are safe in pregnancy and breastfeeding, would you say?
So there is no medication that is FDA approved for use during pregnancy. And so that website that I talked about, one of the things you can read there is that the SSRI that's been the most studied is fluoxetine because it's been around for the longest.
Mhm.
So if patients say, I want the one that we know the most about, then it would be fluoxetine. But in general, I think all of the SSRIs on that website would be considered to be meds that have been used a lot and where there hasn't been a lot of data against them. I think there are nuances. It's important to look at the site because there are nuances with all of these meds. Yeah.
Thank you so much. There's some great questions still in there, but we are unfortunately out of time.
Yeah.
So
Great.
thank you so much. We do have a
You're
talk on
welcome.
ADD, so for those people who put those questions in, and also on memory loss and dementia.
Great. Good to see you. Thank you. Bye-bye.
Thank you. Thanks so much, Dr. Emmerich.
Yeah.